Hey, welcome back everyone to the next video in the series. Up to this point, we've learned about diagnosis, biofilm, and classifications. It's now finally time to learn about treatment modalities, specifically non-surgical and surgical periodontal therapy. Let's break down periodontal therapy into 5 clear phases. Now, knowing the order and purpose of each phase is key to treating patients effectively, and it's high yield to know for boards too. So first off is phase 1, which is the preliminary phase. This is where we take care of any urgent issues like extracting hopeless teeth. These are usually teeth with severe bone loss down to the apex, severe caries, or ones with no remaining attachment support. By extracting hopeless teeth, we're removing infection. A high yield point to keep in mind is, for example, you might run into a question that says a patient has emergency extractions. What's the next phase or step? And the answer will always be the next phase, which is the non-surgical phase. So this is phase 2. Now we focus on controlling plaque and removing local factors that are causing inflammation in this phase. So this includes scaling and root planing, antibiotics if it's indicated, especially giving oral hygiene instruction to the patient, and dietary changes like cutting down on sugar or sticky carbs. So we're trying to stabilize the tissue and reduce inflammation without surgery first in this phase. Phase 2, the non-surgical phase, is also referred to as initial therapy. So if you see initial therapy, you need to be thinking of non-surgical approaches to care. The next phase is the surgical phase. So if non-surgical treatment doesn't get us to where we want to be, particularly if there's any remaining deep probing depths or bony defects, we want to move to surgery. So this may include osseous surgery, gingival surgery, bone grafting, things of that nature. So the goal here is to reduce pocket depths, regenerate structures like the PDL, and repair bony defects and soft tissue damage. By the end of this phase, hopefully the disease is under control so we can safely move on to the restorative phase, where we can safely plan implants and other prostheses. We want patients to be periodontally stable before we restore. Otherwise, we're at risk of failure of the restorative work. So think of it like building on a solid foundation. The last phase is the maintenance phase, and this is so important in managing periodontal disease. This is probably the most important phase of periodontal therapy. This includes ongoing care like routine checkups, professional cleanings, and reinforcement of oral hygiene habits. It actually starts early on alongside the other phases, especially in the first year of diagnosis. The goal in this phase is to keep the patient periodontally stable long-term and help prevent relapse. Now that we know the 5 phases, let's zoom in on some high-yield details, starting with the non-surgical phase, also called initial therapy. One important procedure here is prophylaxis, and that's your basic dental cleaning. Hopefully we all know this, and it helps remove biofilm, calculus, and stains from your teeth. Now, a fact here that's board relevant is, yes, things like coffee and red wine stain your teeth, but did you know that mouthwash might be staining them too? There's an ingredient in mouthwash called cetylpyridinium chloride, or CPC, and it can cause brown staining on teeth over time. The key point here is the staining can only be removed, like so, by a professional cleaning, aka a prophylaxis. Brushing alone won't cut it. This is one of those little details that might show up on your test, so keep that in mind. Let's talk about scaling and root planing, or SRP. This is the first-line treatment for periodontitis, and it's one of the most important steps in non-surgical therapy. The non-surgical phase, initial therapy, whatever you want to call it. So here's how it works. Scaling revolves around removing plaque and calculus from above and just below the gum line, removing it like so. Root planing goes a bit deeper. This is smoothing out the root surface by removing rough cementum and removing deposits and endotoxins. So why does this matter? Because when roots are smooth and clean, bacteria have a harder time sticking around and the gums can start healing. You can get healing done by long junctional epithelial attachment. What can we expect after an SRP? Hopefully we see a reduction in probing depths, we see less bleeding on probing, and over time the gums look healthier and they're tighter around the teeth. It takes on average around 4 to 6 weeks after SRP for you to notice these differences at a reevaluation exam. And that's a great sign if you see a reduction in BOP and probing depths. That means the patient is responding well to non-surgical periodontal therapy. A key add-on to the non-surgical phase is antibiotics. Do all patients need antibiotics? No, but some may be warranted. So antibiotics help target bacteria deep in the periodontal pocket, which are the main drivers of inflammation. But here's something important. Antibiotics, as written here, are adjuncts. It's adjunctive therapy. That means they're a helpful addition, but they won't work on their own. You still need the mechanical debridement, like scaling and root planing, to actually clean out the pocket. So which antibiotics should we know? The first are tetracyclines, especially doxycycline. These are great for cases with generalized deep pockets throughout the entire mouth. Tetracyclines can inhibit collagenases, which are enzymes that break down connective tissue, so they help prevent against the periodontium being broken down. A key collagenase you may have heard of is a MMP, or matrix metalloprotease, which breaks down collagen. Now, when taken in a low dose, doxycycline modulates the immune system of the patient. That decreases the inflammatory response, which makes them anti-inflammatory. The next is amoxicillin with metronidazole. This combo is commonly used in stage 3 or 4 grade C perio. Now, stage 3 or 4 grade C perio can also be referred to as just generalized aggressive periodontitis. This is before the 2017 World Workshop, where staging and grading became the standard. So on your exam, it still may be written out as generalized aggressive. Just know that that is stage 3 or 4 aggressive rapid rate perio grade C. So in cases that present like this, amoxicillin with metronidazole is perfect because they're effective against anaerobic bacteria and spirochetes. The last one I want you to know is a minocycline called Arestin. This is a local delivery antibiotic, and it's used when there are localized probing depths greater than 5 that are not healing. So a minocycline is a form of tetracycline. So hopefully that doesn't confuse you, but unlike taking doxycycline for generalized periodontitis to reduce the host inflammatory response, reduced inflammation, Arestin, which is a minocycline, is local and it's antibacterial. It targets the bacteria themselves. Speaking of antibiotics, let's talk about a specific condition that often shows up on exams, and it's called Acute Necrotizing Ulcerative Gingivitis, or just ANUG. So what makes ANUG stand out? Here's the #1 high-yield fact. ANUG causes the loss of the interdental papillae. That's the gingival tissue between your teeth, and on a test or in real life, that's your biggest clue. ANUG has a sudden onset, and it's usually very painful. Other classic signs include inflammation. Just look at how angry the tissue is on the mandibular anterior in this picture. It can be associated with tooth mobility and especially a nasty odor. It smells really bad, and you'll be able to tell when a patient has it. So what causes ANUG? So ANUG typically shows up when the immune system is weakened or oral hygiene is completely neglected. So if a patient has poor oral hygiene, high stress, malnutrition, immunosuppression like HIV or a post-viral illness, they're at risk of getting ANUG. It's basically the perfect storm for bacteria to take over. So how do we treat it? We first want to debride the area by removing necrotic tissue and plaque. We can use a chlorhexidine rinse, which helps kill surface bacteria. And then the key is that we use metronidazole, which is the antibiotic that targets the anaerobic bacteria involved in this disease. Let's take a minute and do an example question. So in this question, we have a 68-year-old male. Chief complaint is that his gums hurt. They are allergic to penicillin. They consume 3 drinks per day. And our current findings include a 7mm probing depth on number 30 with a visible radiographic vertical defect. So what is the most effective pharmacological treatment for this patient? Go ahead and pause this video and think this one through. The correct answer is C, minocycline, and the brand name used in perio is Arestin. So minocycline is a tetracycline that's used when there's localized probing depths greater than 5mm, which we have in this case. Next up, we have a female, 18 years old. Chief complaint, my gums bleed when I brush. She has no significant past medical history, and our current findings include calculus buildup on the lingual surfaces of mandibular incisors and the upper molars. Go ahead and pause this video, look at the answer choices, and resume when you're ready. The correct answer is B, full mouth SRP. So a full mouth SRP should be performed in order to achieve plaque control throughout the entire oral cavity, and not just in areas where it's visible that there's calculus built up. Even though we don't get a ton of information in the findings box, what they're really asking us is, do we treat selectively or do we treat entirely within the full mouth? And we always treat the entire oral cavity as part of initial therapy. Now that we've covered non-surgical treatment, let's move on to surgical therapy. And this is the next step when scaling and root planing alone isn't enough to resolve the disease. So let's start with flap design because it's one of the most testable and clinically critical components of periodontal surgery. So why is flap design important? Well, when performing surgery, the goal is to create a flap that gives us access to the bone and underlying roots while protecting the surrounding structures and allowing for proper healing. So here are some key design principles. The first is we want to avoid vital anatomic structures like nerves and vessels, so like the greater palatine artery or mental nerve. The next is we always want to make incisions over intact bone. Yeah, we're over intact bone here, and this supports healing and flap stability. Ideally, we want rounded corners because sharp corners are more likely to tear or catch on instruments or bone. And a big point is we want a wider base apically. So this ensures blood supply reaches the entire flap, especially the top or coronal part, which is the most prone to ischemia. So let's go ahead and make our incisions here. And then on the other side here, and we will reflect this flap. And this exposes the underlying bone completely. So this is called a full thickness flap because it includes the periosteum. Let's say the periosteum is not included in the flap, it's still attached to the bone. This is called a split thickness flap. But in this case, it's full thickness because the periosteum is reflected in the flap. A quick but important note about flap design is papilla preservation. So what happens in a conventional flap? Well, the incision is made through the interdental papilla, and this can sometimes lead to loss of the papillae, which leads behind a black triangle, which is a cosmetic issue, can trap food. So we typically use a papilla preservation flap. As the name suggests, it preserves the papilla. So instead of cutting through the middle, the incision is made around the line angles of the tooth, carefully working around the papilla. Now it's subtle, but notice the difference in these two pictures. This helps keep the tissue intact, which is especially important in the aesthetic zone in cases where you're doing regenerative procedures and want to maintain soft tissue coverage. A part of surgery is bone grafting, and there's three main types of bone grafting functions, commonly known as the 3 O's. The first O is osteoconductive. So these grafts act like a scaffold. They guide new bone to grow around it. All bone grafts are osteoconductive. I think of conductive in construction, and you think of a construction site having a lot of scaffolding, right? This acts as the scaffold for new bone. The next O is osteoinductive. These induce nearby stem cells, osteoprogenitor cells, to turn into osteoblasts, which are the cells that make new bone. So think that they stimulate your body into making new bone forming cells. They induce it to happen. The last O is osteogenic. These grafts contain live osteoblasts, meaning that they directly contribute to making new bone. This is usually found in autografts, which is bone taken from the patient themselves. But where else can we get bone? There are several types of bone grafting materials that you should be familiar with. Like I said, autografts are from the patients themselves, hence the prefix auto. Allografts are from another person, typically a cadaver. Xenografts are from an animal, typically a cow, and that's referred to as a bovine graft. You'll also see porcine grafts, and those are from pigs. Alloplasts are the last ones, and those are synthetic. That's man-made, non-biologic grafts. So it's important that the alloplast is biocompatible with the patient's natural bone because it's synthetic. Autografts and allografts are osteoconductive and osteoinductive, whereas autografts are also osteogenic, like I mentioned in the last slide. Let's get into mucogingival surgery, which helps fix issues with the gums, like not enough keratinized gingiva or recession. So there's two major types that you need to know. The first is a free gingival graft, or FGG. The main goal of a free gingival graft is to increase the width of keratinized tissue. So remember, keratinized tissue extends from the free gingival margin down to the mucogingival junction. If that is non-existent or extremely narrow and thin, a free gingival graft will be great. Sometimes it's used for root coverage, but it's not ideal because it doesn't look that natural when the graft heals. It kind of has a tire patch appearance, so it's not preferred in aesthetic areas. So you can think of a free gingival graft as your go-to for adding more keratinized tissue. The other main grafting technique is called a connective tissue graft, or sometimes called a subepithelial connective tissue graft, CTG. The main purpose of a connective tissue graft is root coverage and thickening the tissue. As the name suggests, it includes only the connective tissue, not the epithelium, unlike a free gingival graft. It blends better and gives more natural aesthetic results. So a connective tissue graft is your top pick when you want root coverage and a good cosmetic result. Both grafts usually take autogenous tissue from the roof of the patient's mouth or the hard palate, and both lead to the formation of long junctional epithelium, which is what attaches the new tissue to the root surface. Lastly, let's talk about some facts about post-extraction healing. So when a tooth is extracted, you're going to get some resorption of the ridge in that area. Following a tooth extraction, the greatest dimensional change is in the horizontal aspect. There's horizontal ridge resorption, which is about 30 to 50% of the width in the first 6 months, while vertical loss is less pronounced. It's averaging around 10 to 20%. So these values are approximate and can vary, of course, by patient and extraction site. All right, our last example question. We have a 50-year-old male, and he's concerned about some gum recession. There's no significant past medical history, no known drug allergies, he's not taking any medications, and our current findings include 3 to 4 millimeters of gingival recession on number 25. So we're dealing with a mandibular central incisor, and he has some mild dental sensitivity associated in that area. And there's no history of previous periodontal treatment. So given that, what is the best management plan for this recession? Please pause the video and then resume when you think you got it. The correct answer is A, a free gingival graft. So this is a type of grafting technique in mucogingival surgery, and we use it to increase the width of keratinized tissue, which in turn helps with recession. Although a connective tissue graft is the gold standard for root coverage, it's not one of the answer choices, so that's why A is the correct answer. All right, great job everyone. Here's our summary for non-surgical and surgical therapy. So to start, an SRP is the first step in non-surgical, also called initial therapy, to treat periodontitis. Next, amoxicillin and metronidazole are the most common adjuncts for treating generalized aggressive periodontitis. In regards to flaps, they need to avoid vital structures and to be placed ideally over bone. And lastly, autografts have the 3 O's. They are osteoconductive, osteoinductive, and lastly, osteogenic.